So good morning and welcome everyone. Thank you for joining this webinar. I'm Jo Bibby. I'm the Director of Health at the Health Foundation, and I lead our strategic priority to improve health and reduce inequalities. And I've been struck that since the new year, a week hasn't gone by without some reference to the challenge of poor health in the UK, whether it's our own Health Foundation report on health and health inequalities in Scotland, whether it's statements from the current Chancellor about his concerns of rising in ill health becoming a brake on recovery, or this week, another report from Steve Webb, former Pension Secretary, outlining trends in ill health among working age adults. So this morning's webinar is a timely opportunity to unpack some of these trends and understand the issues they present to politicians, policymakers, and also how they play out differently across the regions and the population. The event is being recorded and a video will be available on our website within 24 hours, and the subtitled version will follow shortly. Just to outline how we're going to run the next hour and a bit, we're going to start the morning with a presentation from Dave Finch, who is the Assistant Director of Healthy Lives at the Health Foundation, to provide a context to the discussion. We're then going to hear from Jonathan Ashworth MP. Jonathan's the Shadow Secretary of State for Work and Pensions, but before that he held the Shadow Health and Social Care Brief, and he also, before his political career, was Special Advisor to Gordon Brown during his time as both Chancellor and Prime Minister. We're then going to hear from Dr. Shabna Begum, who's a Senior Researcher at the Runnymede Trust. Shabna oversees the delivery of all their major research programs and has expertise in racial inequalities in education and access to housing. Shabna published 2 papers last year, Falling Faster Amidst a Cost of Living Crisis, that looked at poverty, inequality and ethnicity in the UK, and Broken Ladders, the myth of meritocracy for women of colour in the workplace. We'll then hear from Zoe Billingham, Director of IPPR North. IPPR North are a leading voice in regional inequalities and the solutions needed to address them. Zoe was formerly at the Centre for Progressive Policy and before that a civil servant in the Treasury, as well as being Economic Policy Advisor to the Deputy Prime Minister in the coalition government, Nick Clegg. And then we'll round off the panel discussion with some perspectives from Richard Sloggett, who's the founder and Programme Director for Future Health. He previously worked at Policy Exchange, an influential think tank, and before that was Special Advisor to Matt Hancock when he was Secretary of State for Health and Social Care. And Richard worked on a number of things there, but including the 2019 Prevention Green Paper. So we've got a great audience here today. Really pleased you can join us. We will be taking questions after a panel discussion. So use the Q&A box at the bottom of the screen to submit questions. You can upvote other people's questions if you want to see them answered, and we'll, using the thumbs up icon next to the question, we'll try and answer as many as we can. And also we did receive some questions in advance, so thank you for people who did that. And we'll be weaving some of those themes into the discussion. So finally, before I hand over to Dave to do the introductory presentation, today's hashtag, if you want to tweet, is #BuildingResilience. And I'm now going to hand over to Dave Finch to provide a bit of context for the discussion.
Thank you, Jo, and good morning, everyone. I'm going to start with a bit of an overview of some health trends and different patterns of health, and then provide some examples on the extent to which some of the sort of past government spending decisions and priorities have supported a prevention or kind of early intervention approach, and then finish off with some reflections on some of the elements needed for taking a kind of prevention approach in future, and which hopefully will also help to feed into some of the responses. I'm going to start with, on the next slide, with a reminder that we can move to the next slide. Just a reminder that in the decade before the pandemic, life expectancy growth had stalled. So this chart is showing how there'd been continued fairly rapid improvement in a period measure of life expectancy since the 1980s, and in fact in the decades before that. But then that stalled after 2011, and the dashed line is showing you the kind of if that historic trend had continued, and the solid line is showing how that growth and improvement effectively flatlined. It also includes, because this is a measure of the mortality rates of people in each year, then which is effectively an indicator of our current health. It also includes the impact of the pandemic, which is the dip you can see in the final year there. But also around the same time period, there was in our next slide, there was an increasing share of the working age population reporting long-term sickness, which is the line here is showing that proportion growing over time. This has been a fairly gradual thing, but been building and kind of seems to have accelerated slightly since the pandemic. Well, that's partly about demographic pressures. And one of the main drivers of this has been an increase in mental health conditions. So we had both, over a similar period of time, we've had both our longevity, improvements in longevity stalling, and actually the share of people who are experiencing long-term sickness also growing. And I think explanation of these trends have included a kind of austerity of the 2010s, both around public services and social security. But I think it's important to recognise that's not the only explanation. That kind of period of austerity also included the start of an unprecedented stagnation in real earnings growth, and our income and living standards are also really vital to our health. And that's because our health is predominantly shaped by the conditions in which we live, such as the work we do, our education, where we live and socialise, and also the food we eat and the food environment that shapes our choices there. So I think it's important to recognise that while kind of public spend provision plays a role, and often debates tend to focus on the NHS, it's actually those other factors at play that are key determinants of our health. And that means that as well as government and different levels of government having a key role to play in supporting our good health, it also involves business, the sector, communities, ultimately people as well. So this isn't purely about that, but what we are focusing on as we move through this a little bit more is how some of the decisions the government have made have supported the maintenance of people's good health through time. And a further thing to point out is how the health of the population also varies significantly for different groups. So on our next slide, which is analysis of primary care data by our colleagues at the Real Centre at the Health Foundation, where they're looking at diagnosed ill health across different regions of England. So the red bars are showing the proportion of people with diagnosed illness. So a longer bar is bad, essentially. And this shows how it tends to be a greater share of the population in northern regions and the West Midlands with diagnosed ill health. So there's which also is in line with some of the very wide disparities in life expectancy and healthy life expectancy experienced across different local authorities in the UK. And that same data on our next slide can also be used to show different rates of diagnosed ill health across ethnicities. And this shows that particularly people from Bangladeshi, Pakistani and Black Caribbean tend to have higher rates of diagnosed ill health. And it's also quite noticeably lower for Chinese people at the bottom. It is worth noting here that this is administrative data, so it does only capture people who actually engage with health services. So it may not be capturing the whole picture, but I think it does help to, it does kind of align with other data sources and does provide a sort of important reflection on how health varies between geographical areas and different groups. And I think just linking back to the determinants of health, often the areas with higher rates of poor health also tend to have high levels of deprivation, which in large part is reflecting the resources available in those areas. One emerging consequence of the growing ill health that I've been talking about is a growing number of people reporting ill health as their reason for no longer participating in the workforce or being economically inactive. So our next chart shows the change in the number of people who are economically inactive by their main reason for being so since around the start of the pandemic. This does tend to reflect a kind of broader trend that was happening, a rise in people with poor health being economically inactive, so out of the workforce entirely, that was happening before the pandemic started. But it has become really noticeable that there's been this rise, and it's that specific reason for poor health driving that economic inactivity, and ultimately acting as a drag on the economy, which I think is it's a kind of quite clear manifestation of this kind of the consequences of growing poor health. So that also leads me to a question of how far kind of government spending decisions over the last decade or so had supported taking a more upstream approach to actually stop people becoming ill in the first place, and help to reduce some of the potentially some of these longer term trends that were emerging. And our next slide is a summary. It is taken from some Resolution Foundation analysis back when, I believe it was the budget when Sajid David was Chancellor, if that can be remembered, that if people can remember that far back through Chancellors. And it showed, and this is basically showing how spend has changed across different elements of government departmental spending. And I think the key thing here is that you know, health and social care services in particular, so that acute health need had been prioritised over the decade from since 2009-10, but other areas had their funding cut, and many of those areas are really important in actually supporting good health in the first place, things like education, transport, local government and housing. And then taking a sort of more zoom in on one particular piece of area of government spending, on our next slide we're looking at children's service spending. So this is analysis actually just taken from a report by Pro Bono Economics, which is looking at how different types of spend on family and children's services in local government had changed between 2010-11 and 2020-21. It's all in constant price terms. And effectively what this is showing is the blue areas are spend on things that we might think of as early intervention, and the red areas are things we would think of as later intervention. And over that decade, there's been a really clear shift towards that more late intervention, that services to support acute need, and more funding taken away from areas with more early intervention and with more upstream approaches. I think one of the stories slightly missing from this is that over time, in fact, the budget had been cut, but then eventually as the budget grew, the growth was in more acute need, which kind of suggests that you'd had a shift away from supporting more early intervention approaches as partly fueling a need for more acute spend in the later years over time. And actually now I think spend is broadly about the same, if not slightly higher in some of those areas. Well, clearly it's higher from the chart in those areas from time. Then just a final further example is just looking at household incomes. Clearly incomes are really important part of helping to maintain people's health. It provides an access to resources, and also just to maintain kind of essential needs. And as we're seeing through the sort of cost of living crisis, it's also has a very direct impact through to, or not having enough money has a direct impact through to stress and mental health issues. The lines on this chart are showing income growth over a 5-year period, over 3 different 5-year periods across the income distribution. So with the poorest on the left-hand side and the richest on the right-hand side. And I think the 2 things to notice here is, one, that growth is actually pretty weak by historical standards. So it's around 1%, if not less, a year in real terms. But also in that 2014 to 2019-20 period, there was a real drag on growth at in the poorest third of the income distribution, and that was pretty much driven by decisions made around social security to reduce spend on working age families, which I think just is a reflection then on some of the resilience that was there and available by the time, or that had been eroded by the time that crises hit in the pandemic and now the cost of living crisis as well. So clearly some measures would have needed to have been taken at those times, but perhaps not to the same scale if some of that resilience had been, if people had been more resilient in their family finances before reaching the start of the pandemic. I think, so just to summarise really is, clearly there's some, there hasn't been a particularly strong move towards prevention within those spending plans. There will be examples where there has been more of a prevention focus, but I think broadly that picture is maintained across different levels of public service provision. So what actually is needed to take a more prevention first approach? And I won't go into huge detail of these, but I think one really important element is a need for a cross-government approach, because many of the kind of costs and benefits from taking earlier interventions are often some of the costs fall in different departments to where the spend needs to be to stop that from happening in the first place, and also the benefits can then accrue to other areas. So it's really, we really need some acknowledgement of across government of how policies in one area can affect another department's what another department needs to do. There's also, I think, really a need for a political consensus for taking that long-term focus on prevention. Often the sort of political needs drive a kind of short-term focus, and with changes of government, ultimately you need that buy-in to maintain that long-term approach over decades, essentially, which leads to that need for really long-term planning and investment in taking that approach. And I think also the need to understand that if you're taking that approach, then you actually need to address the underlying causes of ill health and inequalities, and not just some of the kind of the outcomes that are apparent because of the existence of those more structural inequalities. So I think I'll just conclude by saying that clearly, I think this is really important, because those rising levels of ill health in the working age population, I mean, this isn't just a challenge for people as individuals, but it's also a whole society challenge. One clear example of that is the risk of not being able to fill jobs because of constraints on labour supply. Another one is that actually it potentially makes public service provision more expensive and difficult in future, particularly if we take the rise in more people having periods of poor mental health through the pandemic, and then the risk that means more people will experience that in future, and also that's rising among younger people. That has some quite clear implications for provision of public services in future as well, making it harder to do that. Whereas if you'd done more to prevent some of that appearing in the first place, then potentially those sort of costs would be reduced for you. Thank you.
Great. Thank you, Dave. So I think that really sets the discussion up very well. And at this point, I'm going to hand over now to Jonathan Ashworth, who's going to talk a little bit about Labour's plans to tackle economic inactivity and the case for prevention.
Oh, well, thank you very much, Joe, and thank you, David, for that first-class presentation. And can I just start by saying how delighted I am to be back here at a Health Foundation event. For the many years that I was Labour's health spokesperson, I could not have done my job effectively if it wasn't for the research, insights, policy contributions of the Health Foundation. Hugely relied on all of your output. So I'm really pleased to be here and associated with you this morning. And I just want to make a sort of just pick up on that reflection that you offered at the start there, Joe, about how there's been a lot of focus in the newspapers since Christmas around ill health because of this impact on labour supply and so-called economic inactivity. And I think, although I might be wrong, this feels to me like the first time that the prevention debate has been discussed in the way it should be. It's often discussed in the media, if you like, or in public forums, if you like, as a debate around to what extent should the so-called nanny state interfere with people's lives. And I think those of us who have worked in health policy or social policy have known that, well, that is most certainly an interesting debate about liberties and trade-offs. It's at the more frivolous end of this. If you want to improve population health, you need to intervene in different ways through different government departments. Now, health prevention was always one of my big priorities when I was the Shadow Health spokesperson. But I also knew that in reality, if I was ever fortunate enough to become the Secretary of State for Health, that to really tackle this prevention and to improve population health across the board, it would have taken way more than the Department of Health. It would have taken every government department seeing it as a big priority. Unfortunately, just to make a party political point here, although I'm not going to make a party political contribution, Keir Starmer has just announced some missions in tackling health inequalities. is one of the missions, or part of one of the missions that he's announced, which I think indicates that a future Labour government will want to take prevention seriously. On saying that, though, what I've been very struck by moving from the health portfolio to the work and pensions portfolio in the last sort of 18 months or so, is the extent to which so much working is completely siloed, and that the debate that takes place at a work and pensions level about how to get people into work has generally, hitherto, has begun to change in these last few months. It's generally not really taken into account health and population sickness in a way in which it should, I believe. A traditional approach to getting people into work, and an approach which has been part of the welfare state in one way or another since Beveridge, but really came to the fore under the New Labour years, and was taken further under the early part of this government, particularly when Ian Duncan Smith was Secretary of State, was to try and get people into work through either dealing with disincentives in the benefits system, or applying ever harsher conditions to your form of unemployment benefit. In other words, you would have your unemployment benefit cut if you were not prepared to engage with activity, job-seeking activity. The second part of a traditional employment support service has been to offer people with low skills, limited work readiness, so low-level forms of training, CV writing skills, presentation skills for an interview. All of that is important, and I would, and you do need conditions attached to the unemployment benefit claiming, and that will always be the feature of the system. But I think what we now really understand, or should begin to be, or policymakers need to understand more, is that there are ill health is a limiting factor on someone's ability to move into work, but the system needs to put in place reforms in order to help people with ill health find quality work, because we know this can be mutually reinforcing. Being out of work for reasons of ill health can risk you being out of work for a considerable amount of time, which in itself worsens your health if you cannot find suitable, quality, flexible work for you. So some of the reforms that we have been talking about is, if you like, to apply the sort of the years of working in health policy, if you like, to our reforms to the social security system. Should I be fortunate enough to be the Work and Pensions Secretary. So we put forward some proposals which I think would help people move into work and deal with this issue of labour supply. And we do need to deal with it, because being out of work, I strongly believe, is bad for you, particularly if you are a young person. And when we've currently got around 1 million people out of work, young people out of work, some of that is ill health. A big chunk of that is ill health, particularly mental health and anxiety. But some of that is traditional youth unemployment, job seeking. Well, we know if you're out of work for a particular amount of time when you're young, it risks a life on the margins for you for the rest of your life. It's really important to help young people get into work. So some of the reforms that we are proposing, I think, bringing the my experience of health into the DWP are as follows. So I don't need to go into the technicalities about work capability assessments and the benefit rules, but in essence, if you have gone through a work capability assessment, which is a really arduous, horrible process to get an enhanced level of benefit because of ill health or disability, that process is such a miserable process to go through that it acts as a barrier for you wanting to come off that enhanced level of benefit to even try out work. So we've suggested that if people are in that pool of people, if work is appropriate for you, you should be able to try work without the risk that if it doesn't work out for you for whatever reason, that you have to go through a work capability assessment, reassessment, because the process of it is horrendous, and that in itself acts as a barrier for people trying to see if they can move into work. We've also proposed reforms to something called Access to Work. This is the grant, if you like, that is available for people who have a disability or have a mental health problem, but would want to move into work, to help people get reasonable adjustments in the workplace. There's horrendous waiting lists for this at the moment. I had a constituent who who'd been offered a job, but was told he had a 26-week wait for his Access to Work assessment. So how on earth is that individual supposed to start work when he wants to start work, when he was told he had to wait 26 weeks? We want to fix the waiting list, and we also want to give people in principle awards. So rather than waiting until you've accepted a job and then you apply, you should be able to know in advance what allocation you would get. And again, we think that would help people move into work. The third thing we want to do is move away from this big national contracting that goes on in the DWP. The DWP effectively spends, well, it depends on the economic circumstances, but at the moment it's spending some billions nationally contracting with the traditional outsourcing firms who then offer sort of CV writing skills and things like that to unemployed people. It's only people who are job seeking. It's not the economically inactive. It's those for whom the job centre thinks could deal with have extra help. We actually think it'd be much more sensible to devolve these budgets to local areas, like a little bit has been devolved in Greater Manchester, for example. So local areas can put in place more tailored support for people, not just for those who are unemployed, job seeking on universal credit, but for everybody who's out of work, whether or is economically inactive for reasons of sickness, if they want to engage with that level of service, and allow, for example, Greater Manchester, the West Midlands, etc., to put in place their own bespoke, tailored solutions, rather than the idea that I and the DWP can design everything from Whitehall. I'm very struck that, you know, in the NHS, there's we always go through different reorganisations in the NHS, but of course it was, you know, famously said that Bevan wanted to hear the clang of the bedpan ringing through his office when it fell in a hospital ward in Tredegar. In the DWP, it is literally like, I'm not quite sure what the right metaphor is, but if a stapler falls off a desk in a job centre, it kind of, you know, the DWP Secretary of State hears it in his office. It is ridiculous the extent to which it is so centralised. And I think decentralising a lot of the way in which we offer employment support, so local areas can design programmes which are more suitable to the local needs, is the way we want to go down. And but finally, I think bringing together health and work is really important. There is a health and work unit which spans the Department of Work and Pensions, the Department of Health. We would want to expand that. And the thing that we are really exploring and looking at now is how we can also put employment advice in health settings. There are some pilots where there are employment advisors who work in mental health services. One or two examples of where employment advisors are working in addiction services. I visited one in Nottingham about 2 or 3 weeks ago. There is a pilot now putting employment advisors in, I think, primary care in the West Midlands. We're studying these different pilots very carefully because we think more can be done to support people with their health conditions to find work. Because what you find is a lot of the people a lot of the people we are talking about here do not necessarily want to engage with the job centre, because the job centre has become far too associated with benefit cuts and sanctions and its punitive approach. So we are exploring how we can take the learning from these various pilots across the country and see how that could be rolled out nationwide. And I think this is, if you like, the new frontier in employment services and the new frontier in social security, better joining up what our DWP and benefit system does with our health services. And that is something that I think will be a big priority of the next Labour government. So there's just a few reflections from me. I look forward to getting more into the discussion as well.
Great, thank you for that, Jonathan. So I'm now going to turn to Shabna, and we saw from the slides that the sort of burden of ill health does fall disproportionately heavily on some ethnic minority communities. So we'd like to hear your perspective of how racial discrimination in wider determinants of health have a part to play in this.
Thanks, Joe, and thanks, Dave, for the slides and the presentation, and to Jonathan for your thoughts just there. So at the Runnymede Trust, we welcome this move towards a more preventative approach in the discussions here, because we would argue that a preventative approach is critical to achieving racial justice and a fairer and more sustainable economy. And I guess I wanted to make 3 quick points. Firstly, the 2021 census tells us that 18% of the UK population are from Black and minority ethnic backgrounds. And given that our communities are more likely to be negatively impacted by those wider determinants of health, it goes without saying that addressing those problems will likely benefit that population more. But we're really mindful that doing this kind of preventative work in a universalized way without insight from a race equality perspective or from that wider intersectional perspective will miss some of the structural and institutional processes that have designed that unequal landscape in the first place, and therefore you would fail to deliver the kind of changes that we really need. So, for example, picking up on Jonathan's point about work there, if we know that work is one of the key determinants of health, then our report Colour of Money, which predates the pandemic, was already identifying how persistently unequal the labour market is for our communities, and that despite significant educational attainment gains, those are not reflected in the kind of work and progress people, our communities are making in the workplace in terms of pay, conditions, the security of the kind of jobs that our communities are doing. Joe, you referred in the introduction to the Broken Ladders report that we did last year, and that was looking at women of colour in the workplace, and picking up on the point that Dave made in his presentation about mental health. 75% of the women in that report that we surveyed reported having experienced racial discrimination, and talked about the mental health and well-being impact it had on them, and the number of days that they took off sick, leaving jobs that they were good at because of those conditions. And so thinking about preventative health policies and what they might look like in terms of improving work has to take that racialized perspective. It has to respond to those persistent inequalities and discrimination in the workplace. It can't take just that universalized approach. The second point I wanted to make was thinking about what we should have learned from COVID-19 and the pandemic. So again, we published a report during the pandemic called Overexposed and Underprotected. And we highlighted what we all know here, that Black and minority ethnic people were overrepresented in all of those figures. And actually our most recent analysis of some of the data shows that a Bangladeshi man was 3.1 times more likely to die than a white British man. And despite the kind of unhelpful and really misleading and really quite dangerous explanations at the beginning of the pandemic, when we were talking about genetic differences and vitamin D deficiencies, we know that it was actually the disproportionate exposure to the inferior determinants of health, like poor housing, like the insecure and frontline facing employment, which had less kind of flexibility around it. And also, as Dave pointed out, the lower levels of financial resilience that really contributed to those death rates. And so if we take housing in the context of COVID-19, we know that the housing conditions and overcrowded housing conditions in particular had a real impact on COVID-19 mortality rates, particularly for the Bangladeshi community, which again came up in Dave's presentation. And the report that we published late last year, Falling Faster, was about the cost of living crisis and how deep our communities are in those statistics of deep poverty. And so again, housing is critical in that discussion and in that conversation. So we identified that Black minority ethnic communities tend to be exposed to the worst excesses of the private rental market. They have less access to home ownership, and they tend to be in the worst quality social housing as well. And so that we saw had fatal consequences during COVID-19 and the pandemic, but we've seen that play out with Awab Ishaq, for example, the 2-year-old who died in Rochdale. So again, I would argue that any preventative kind of policy-making approach needs to address that racialized dynamic. And if we want to connect that back to the kind of economic case that we're talking about, well, we all know very, very well that during the pandemic, many of the workers that kept the economy ticking over from those Black and minority ethnic communities who are forced to live in that bad housing and forced to move around. And so if we want to build a sustainable and fair economy, then we do need to think about how we house those communities. And my third and final point is that even though I think there is growing awareness, and Dave's slides presented some of the statistics which are beginning to recognise that Black and minority ethnic communities tend to be overexposed to those negative wider determinants of health that lead to poorer health outcomes. There's still a shyness about naming that overexposure as being related to racism. We often kind of talk about it as socioeconomic characteristics, as though it's coincidental and accidental. But from the Runnymede perspective, and from the research that we know that we've done ourselves, and from the research that exists, it is structural and institutional and interpersonal processes and practices that are rooted in racism that mean that Black and minority ethnic communities are disproportionately in those demographics. And so we have to recognise the racialised nature of the wider determinants of health. And I would also say we also have to recognise the impact of racism within the healthcare system as an institution as well. So when we look at Black maternal health, we know that there have been persistent problems in terms of outcomes for Black women, who are 4 times more likely to die in childbirth or from related complications, and Asian women, who are 2 times more likely. And really, finally, in terms of that mental health point that Dave brought up, and also that Jonathan has brought up, again, thinking about how the healthcare system deals with the mental health of Black minority communities, we know that they are much less likely to receive healthcare treatment for mental and emotional problems, but Black people are 4 times more likely to be detained through a police intervention, which is related to the Mental Health Act. So again, that kind of the inadequacies of the health system in terms of dealing with some of those issues as well needs to be addressed. And so at the Runnymede Trust, we would argue that there is a really strong racial justice case for investing in an intelligent preventative approach. And we think that's the way to build a more sustainable and fairer economy.
Great, thank you very much, Shabna, and some really sobering statistics there. So I'm going to now turn to Zoe. Zoe, you're involved in the IPPR's Commission on Health and Prosperity, as well as lots of work looking at regional inequalities. So we'd like to hear your perspective on those issues.
Yeah, thanks so much, and for this conversation today, which is of course a very timely moment, both because of the statistics that were set out at the beginning about the number of people who are out of work due to long-term sickness, and also of course with a view to kind of manifestos being written at this moment in time and making sure the prevention agenda is at the heart of any health agenda that each political party wants to take forward. And we at IPPR and IPPR North, where I'm director, are totally supportive of prevention being the way to, both in terms of the economic case, in terms of reducing the prevalence of poor health and facilitating people to work, but also of course as a moral case. And as we've just heard from Shabna, the fact that it falls disproportionately on Black and minority ethnic communities, and regionally from our perspective, of course, we see certain places across the UK that are less, both more deprived and therefore have a higher prevalence of ill health. And so I'll talk about that in a second. So I think there's we've got to consider all of these factors in who we're targeting this prevention agenda at. And I would just say also that we've got to recognise the complexities of people who are out of work due to ill health. Our research at IPPR has found that these people often have multiple long-term health conditions, often have mental and physical health conditions. So we've got to kind of recognise that there's a complexity of people who are out of work due to long-term conditions at the moment, and address that head on. And that's why our Commission on Health and Prosperity is very much speaks exactly to this agenda, this idea that, you know, a fairer country, a more equal country will be a healthier country, and in turn a healthier country is a more prosperous one, and that's at the core of our commission. But just finally, I just wanted to touch on this place dimension. I think work that the Health Foundation has done looking at the link between poor health and deprivation is totally clear. I mean, this is a link that we cannot ignore. As we saw in David's presentation at the beginning, the very things that are investments in good health, and that's quality housing, as Shabna was just saying, as well as public health, which of course is local government's remit. Let's not forget that, have been cut by over 50% in the last decade. Where I'm speaking to you from in Liverpool, a woman on average can expect to live 58 years in good health. So that's 10 years before she's expected to retire, you know? So we have this absolute kind of discussion about the retirement age, but actually the real discussion is about ill health and the amount of time that people are living in ill health. But just to re-emphasize, you know, public health has been within the remit of local government for almost 10 years now. That budget has been cut and diminished over time. And what does that mean in practice? That means we're cutting budgets for anti-smoking strategies and advertising, sexual health. You know, like, these are real concrete areas of spending that have a direct impact on the prevention agenda, and yet they've been cut over time. And I think this is a question that I would really like us to pick up in the discussion, is that obviously there is, you know, the way that the public finances is being framed at the moment is very much one of, it's a very constrained setting, and every party is speaking to limits on what they're willing to spend in public services, and that includes the prevention agenda. So are parties willing to make the investment to see the benefits in the future of the prevention agenda? And I guess that's the sort of the difficult exam question that this leaves, this topic of prevention leaves us with, because it does need investment. But in my mind, and in very much the mind of the commission that we're running, it is an investment in the future, both economically and morally and socially. So it's an imperative, and the question is, how do we convince people to take up the mantle? Thank you.
Great, thank you, Zoe, and I'm sure we'll come back to that. So I'm going to turn now to Richard as our final panelist to set the scene. And I think I'm going to we're going to pivot a little bit here, because we've heard a lot about the role of government, and government obviously has a big role to play, but also private sector employers and regulation are another dimension to prevention. So Richard, I'd like to hear your views on the role of regulation in prevention.
Yeah, thanks, Joe. I think Zoe's really sort of hit the nail on the head there. It's what does the rubber hit the road here in terms of, you're going to deliver a more prevention-led system. You're going to have to invest in the prevention-related elements that are then going to give you those benefits. I mean, when I was in government, I worked, and it's great to see a couple of people in the comments mention the Prevention Green Paper from 2019, which I think is something like 1,300 days without a reply. So I'm not sure if Jonathan's still tabling PQs on health, but it would be a good one to ask. And my reflections when I worked on this were, there was a huge amount of appetite. As soon as we said at the Department of Health, we're doing something on prevention, virtually every other government department came to us and said, how can we input into this? This is great, we're totally on board. Now, part of that crudely was due to the fact that, as Dave's slides suggest, there was finance and money in the Department of Health, and there wasn't in other government departments. So sometimes ministers thought, actually, we can go to the DH and we might be able to get some joint working budget. But the idea of working sort of on a cross-government basis, there is genuine appetite to do it. One of my concerns, though, is actually practically, how do you make that actually work? And is there any examples or evidence of where you've had, on sort of public service transformation or an issue such as health inequalities, you've had different bits of Whitehall coming together on a regular basis, forming an agenda and driving that agenda through on a consistent basis? And I was really struggling with examples of where that's happened. I think when you think about sort of cross-government sort of cabinet level style committees, they work for crises, or they work in the sort of defence or security space. Can you get something that genuinely practically works when you're trying to bring all these different units together? Someone mentioned in the Q&A the health and work unit, and there is a health and work unit. You might not have heard much about it. It works between the DH and the DWP. And what we found was there was actually quite, when you started to have the conversations, there was actually quite, as Jonathan said, there was quite a good set of alignment. Particularly, we were looking at this through musculoskeletal conditions and mental health, two huge areas of spend. And if you could tackle those effectively and work with business, you could actually genuinely start to see some benefits. But as soon as we brought in BEIS and Treasury colleagues, Treasury said, we're not going to give any business benefits, or we're not going to give you any funding for doing this stuff. and Bayes basically kicked us out on the fact they didn't want to see any regulation on business, and that was 3 or 4 years ago. But the reason I highlight it as an example is not only the sort of subject matter today, but the kind of policy solution that we're trying to come up with here is, if you're forming cross-government committees, sounds like a great idea, but practically it involves, you're going to have to work and sweat that really, really hard and be really clear about what it is you're trying to achieve. And frankly, it's got to be prime ministerially led in order to frankly get any traction. And I was really encouraged today to hear Keir Starmer set out one of his missions about health inequalities. I think there's been a real, one of my big concerns as we've come out of the pandemic is that we've drifted into a very traditional UK health policy space, which is it's the NHS, it's waiting lists, it's quite target driven. What we've lost through various different reasons, some of the political turmoil from last year, the looming election, we've lost the kind of, what did we, as Shabna said, what did we learn from COVID about our nation's health, and how can we sort of build a better, oh God, do I want to use the build back better phrase? Probably not, but do we want to build back better or not? And I think where we've sort of drifted to health policy wise is this very kind of NHS lens. And what we really need to do is broaden it out. Because when I went back, if I go back to 2018-19, we actually didn't look at prevention through the economic lens. We looked at it through the health budget lens. And what we were saying was, look, Sally Davies came to us and said, look, the thing you've got to try and prioritise is prevention. Look at the demand going up. We've got to try and shift it. That's not to say the economic arguments weren't strong, but actually that was where we were coming at this whole agenda from. And I think what we've seen in the last 10, 12, sort of 13 years is it's been, I would say the pace of this has really struggled. So people have accepted the premise that prevention is better than cure. We need to try and shift the policy framework. But it's actually, from a sort of government perspective, it's been really hard politically to get the change to actually happen. So if you go through each of the prime ministers, let's discount Liz Truss because she wasn't prime minister for very long. Let's go for the other three. So if you go for David Cameron, started off quite sceptical, eventually got to the sugar tax. Theresa May came in, said, I'm going to be quite sceptical, eventually got to the childhood obesity plan. Boris Johnson came in and said, I don't like the sugar tax, I might get rid of it. Then says, eventually I'm going to bring forward an obesity strategy. We've had lots and lots of false starts. And I think the big challenge for the next government is not only Zoe's sort of excellent exam question on how are you going to raise the revenue to deliver the fundamental structural change, it's how are you going to sort of structurally organise yourself within government, and how are you going to work at pace to get these sorts of things moving. If I give two recent examples, one is the health inequalities white paper. Again, it's got completely dropped due to political change. It was pretty much, from my understanding, ready to be sort of brought forward and brought out. There wasn't going to be significant funding attached to it, but I think that would have been your response to your prevention green paper. And then the Khan review into smoking, really, really good piece of work, independently led, commissioned by Sajid Javid, again, just gets completely lost in the changes that we need to see. So my challenge to whoever takes over as next government in 2024 is, how are you going to structure yourself in a way that you can work collaboratively, and that within that creative tension between departments, but also deliver at pace? And can you make some 100-day style commitments which can actually start to drive it? And then how are you going to pay for elements of this? Because if you're going to deliver prevention, you're going to have to find upfront investment to deliver that. So Joe, those are just some of my reflections from as a very frustrated policy person who worked on a document that hasn't necessarily ultimately delivered from a few years ago. And I hope that's helpful to tee up the rest of the conversation.
Great, thank you, Richard. Okay, so we're going to have a little bit of panel discussion, picking up on some of the themes that have been raised and questions that we had beforehand. Also, I've seen lots of questions in the chat, so thank you for that, and we will come on to those. We're also going to open a poll. We thought we've got, over 1,000 people on this webinar, which is fantastic, and you will all have lots of great ideas. And although a lot of what we're talking about here is what needs to be done in the longer term, what we'd be really interested in is what's one thing you could do today that would help prevent future ill health. So we know there's a whole range of different people on this webinar, but please do share your ideas in the sector that you're working in. But what would one thing you could do today that could prevent future ill health? So that's open if you want to answer that. And then I will also ask panelists for their sort of one-liner on that as we close. But I'm now going to just go pick up sort of one of the things that we've sort of touched on, but not fully named, which is really public attitudes towards prevention. We know that politicians, are guided by public priorities, quite rightly, and we know the public put kind of NHS sort of very much at the forefront of their priorities. So I think the big challenge for us as a community is how we take the prevention arguments and case to the public. And I was going to start actually with Shabnam, because as we saw from the data, Black and minority ethnic communities, they have very high acute needs. So clearly those acute services are very important. But what's your experience of engaging those communities in the prevention arguments, and what can we learn from that?
Yeah, so I've got, I don't know how this answer will go down, but I guess in terms of the research that we do and we report, lots of our communities reflect on that and say, we know that, you're not telling us anything new with the research. You are describing our everyday lived experience. And so I think from my perspective, even though we haven't kind of directly asked this kind of question, my experience is that our communities are very well aware that our housing and our work conditions are absolutely at the root of many of our health outcomes and experiences. And so I think that it's a really difficult question, isn't it, Jovi, where, do you deal with the immediate urgent needs? Of course you do. You need to have that investment to make sure that people are well here and now. But most of our communities, and all of the conversations that we have, for example, around work, people, I was one of the lead researchers on that Broken Ladders piece of work. And the kind of mental health and well-being situations that people were describing in that work, they were talking about, we experienced this when we were in the workplace, when we were starting out in the workplace 30, 40 years ago, and now our daughters are experiencing the same challenges. So that need to address that longer term kind of issues within our work, within our housing, within our lived environment are very much alive in terms of the discussions and the conversations and kind of ambitions of our communities.
Yeah, thank you. So I'm kind of hearing here that perhaps politicians just need to be a bit bolder. And this is something we find when we do more deliberative work, that people understand what's making them ill, and maybe there's just something about being bolder about acting on these things.
Yeah, I'd absolutely agree with you on that. That I think that people are very much aware of what is making them sick. They know it, live it every single day. So yes, I would agree with that.
So John, I'm going to turn to you, because obviously you've had the health brief and now you've got the work and pensions brief. So how are you going to be making the case to the public that the investment and the change you want to see in those services is going to be ultimately kind of beneficial for society? How do you see that prevention case?
Yeah, well, just a sort of someone said to me when I did an event for the one of the Royal Societies just after I'd been moved from health to work and pensions. And I remember saying to somebody, I'm pleased to have a new challenge, but I will miss health because my big passion in health was health inequalities. And they sort of said to me, well, if you became the Work and Pensions Secretary, you've arguably got more of a chance to deal with health inequalities than if you actually were the Health Secretary. I don't know if Richard agrees with that or not, but it's pretty clear, isn't it, that income impacts on your health outcomes. You've just seen that in the presentation. We all know that on this call, and everybody watching will know that. I think it is absolutely disgraceful that we've allowed child poverty to increase, whereas the link between poverty and retirement has broken down pretty much. It's not what it used to be in the welfare system. Pension and poverty is also on the increase. But some of the interventions that we would want to take around poverty reduction will have, we would hope, obviously, an impact on health outcomes. But it's also about how you improve conditions in the workplace as well. It's about wages. We've had wages squeezed now for 12 years or so, and the nature of work has become ever more stressful, ever more demanding. The problem that we have, unless we do something to change the nature of work, is that we are at risk of a labour market which is like sort of U-shaped. Lots of very low paid, insecure work at this end, lots of super duper high paid work and then not very much in the middle, that is not, I don't believe, sustainable in economic terms, but that in itself is going to lead to detrimental health outcomes if we've got increasing numbers of people forced into very low paid, insecure, gig economy type jobs, essentially servicing the super duper wealthy. And the second problem is it's become very difficult, or at the moment it looks like it's very difficult to progress at work. This is like caricature, but in the olden days, if you like, it is a caricature to make a point. You could go from factory floor to management. Yeah. Well, in this day and age, how easy is it for you to go from being the Uber driver to the Uber coder? Workplace progression has, in many circumstances, broken down, which has all kinds of economic consequences, which in turn will have different health outcomes. I just want to throw a question out to the panel, and I'd just be genuinely interested in this as well, or perhaps a question for the people following, if they could answer this. I thought Richard's observation that the health debate has returned to a traditional NHS waiting list debate. It's understandable given where the waiting lists are. But in the prevention debate is changing. Now, when I was in health, I was always very taken with the sort of Jeffrey Rose analysis that to improve population health, to improve health outcomes, you had to improve the health of the whole population. Yeah. But increasingly now, people will argue that you can improve health outcomes because of all the advances in technology and precision medicine, rather than their more traditional, take big interventions which target the whole of the population. I would just genuinely be interested in whether there is a tension between those two approaches, or whether modern medicine and so on, and all these exciting things that are happening with genetics and all that, does mean the sort of the traditional Jeffrey Rose approach to prevention is now not as needed as it used to be. That's somebody with no clinical background asking that question, but I remember that was something which was being raised with me by various academics when I had the health portfolio.
Okay, well, I think I'll give Richard a moment to think about that. And I mean, because the Prevention Green Paper did have some work on the role of tech and sort of AI and so on in prevention. So I'll come to you in a moment on that, Richard, if that's okay. But Zoe, I suppose one of the things I wanted to pick up from your observations was, we see the differential outcomes, people living across different parts of the UK. We know there's big differences and inequalities in how funding flows to different parts of the UK. And the case, how do we make that case for fairer funding? And as part of the work you do at IPPR North and with the Commission, what are you seeing the opportunities to make that case for fairer funding flows around the country?
Yeah, so you pick up on exactly the sort of the doubly bad impact of austerity and cuts to public health budgets has been that the more deprived areas have seen bigger cuts. So not only is it reduction in all places, in all areas, but the most deprived places where we see higher prevalence of poor health have seen even bigger cuts. So there's been a sort of doubly bad logic, if you like, in how so-called cost-saving measures have been made, and we will see the costs of them. Well, we are already seeing the costs of those cuts, but we'll see them over time to come too. And I guess our approach to it is very much, as we were saying earlier, is seeing public health interventions as an investment. So I know that the Health Foundation's own work has shown that in every year, if you spend £3,500, like going back to the economic case, £3,500 investing per head in public health, that's anti-smoking, that's sexual health, that's helping prevent and stop the worsening of alcohol and drug abuse, that will save you on average £13,000 a year in the cost of the NHS if you left those people to continue in certain ways of living that kind of lead to poor health. So there is evidence out there, and we kind of go back to it all the time. And I would honestly make the economic case, is very clear, and Health Foundation's work have been critical in making that case. And I think, as I say, the cuts that have been made to the public health budget and how they've fallen by place and by deprivation has been totally perverse. So I think we have to recognise that critical link between deprivation and health, and perhaps change how public health is funded, perhaps based on deprivation, so that deprived areas get a bigger proportion and amount of public health funding in order that they can directly address the issues that they face in their areas. So that would be my pledge to whoever takes up the brief in the next government.
Great, thank you. Okay, so I think I'm just taking the challenge that we had from John, but Richard, I think, we do hear like this, Marmot uses the phrase proportionate universalism. So, we need to have universal offers, but we need to target them proportionately at the people who need the most. We have phrases like precision public health. The Green Paper did talk about some of the roles around tech and AI. So just, your thoughts on how we balance this whole population interventions versus more targeted approaches.
Yeah, I don't think they are sort of conflicting. I think they can actually be completely complementary. I mean, let's take things like planning. So you're not going to be able to do precision planning necessarily, or personalized planning, but what you can do is you can create an environment for communities which is conducive to better health, and that involves a kind of a set of rules and legislative approaches that mean that you can create those environments. On the other hand, we are learning more about people's physiology and how they will respond to certain treatments, and that allows you with technology to start to be able to target some of your interventions and approaches in different ways. And also, we definitely should not ignore people's own engagement with their own health, and how we can use public engagement and the ability with new tools such as technology for those who have access to them to actually start a dialogue and approach which actually can motivate and support people. But I don't see it as a kind of conflicting piece. I think you need to build it as a kind of a sort of collaborative one. And we did talk about sort of this predictive prevention sort of agenda in the Green Paper, but alongside that, we did also talk about the concept of, for example, in tobacco policy, being very supportive for things like polluter pays. So capping profits that tobacco companies are making, which are people who are polluting the health of the nation, which is costing us as taxpayers more money through the NHS and other things, to say, look, we're not going to stand for that. We want to be more interventionist. So I think this is where, and Chris Whitty said this, didn't he? I haven't caught the whole piece. I need to hear it back. But he was at the Health Select Committee this week, and he was saying, look, we need to get, and John was right on the nanny state stuff. We really have got to try and get past this kind of like seeing this as sort of like some sort of left-right binary type of issue. I think when you look at those two pieces, you could see the right as being the sort of tech personal piece, and the left being more of the sort of, let's do sort of, more sort of state levels or sort of local government level interventions. I think you've got to blend them together to get to the right answer. I do strongly believe that what matters is what works. So let's look at the evidence as it's developed and work out what the appropriate blended model is. Just, Joe, if I could quickly add on the framing side, the thing that's always struck me, which is really interesting about public health policy, is actually most public health measures are actually really popular. So from a politician's perspective, I remember when we were in government looking at consultation responses, there was one on energy drinks for under 16s. I think it had something like 90% support from those who'd written in and said, and it was actually Liz Truss, when she was Chief Secretary of the Treasury, I ended up having a conversation with, saying, Liz, she was dead against it, of course. I said, Liz, you'd kill for these numbers. 90% of people support this. It's like, why be on the side of the 10%? But anyway, I'm not sure whether I won or lost that argument. So I think there is an opportunity in the public space to have a genuine grown-up conversation about what an appropriate level of regulation and intervention looks like. And I also think there is something about particular cohorts, particularly parents, who actually probably would want the government to put a hand on their shoulder and say, we can help you by creating an environment that makes your life better and easier. And it's not about nannying, it's about support and enablement. So I just wanted to add that in, because I've always been struck by how difficult public health measures are to get through, despite the fact they are actually broadly quite popular.
Great, thank you. Okay, I'm now going to turn to some of the questions that we have in the chat, and The top question in terms of the most number of upvotes was from Daniel Spicer, and it was a question for you, John. This morning's speech from Keir Starmer, he's saying it's good to see a focus on health inequalities in Labour's missions, but disappointing to see it framed as a focus on the NHS, given the smaller role this plays. So, yeah, putting you on the spot there, how do you think that the need for action on broader determinants is being positioned in the missions that Keir Starmer has set out today?
Yeah, I mean, the thing about these missions that Keir was talking about this morning is that he's presented them as missions, not as traditional sort of key pledges that politicians put on, pledge cards and things like that. I mean, I'm sure as we get closer to a general election, the Labour Party will produce something like that, because that's what parties do at general election time. But the whole point of a mission is it's a recognition that these are cross-government priorities. So he's locating health inequalities in the Department of Health as the lead department. And it's interesting hearing Richard's perspective on that, actually, because there's always a debate about where the lead should be, but that he's locating it there. But I think we are completely, recognizing that it's cross-departmental work, because as we know, and everybody watching the seminar knows, health inequalities is yes about the traditional public health interventions that we've been talking about, and many of the services have been cut back, which we're all very disappointed about. But it's also about the quality of housing, it's about the levels of the adequacy of benefits, it's about wages, it's about the air that we breathe, the food that we eat. So this is a big priority for a next Labour government, and we recognise it's going to take cross-government action, absolutely. And you've also got, hopefully in that government, not just a health secretary in Wes Streeting committed to this. You'll certainly have, if things go where we think would go at the moment, a work and pension secretary who's totally committed to this agenda as well.
Great, thank you. And I think I might just make a plug for a piece of Health Foundation work that we published in January, actually, that was looking at kind of how government needs to organise to make health a sort of whole government mission, and what we can learn from the climate agenda, because that clearly is something that's been embedded across all government departments. So we do have a long read on what we can learn from the climate agenda. Now, we have the question, which I was going to put to Shabna initially, but someone was asking about the different determinants of health and which are the most important drivers. Now, I mean, the evidence does tell us that sort of, it's economic circumstances overall sort of have the strongest patterning with poor health outcomes. But thinking about the work you've done with Black and ethnic minority communities, Shabna, where would you prioritise? I was struck by you saying, 18% of the population, and if we can be getting it better for that 18%, that's a huge gain for the country as a whole. But where would you want to see the priorities for that group?
Thanks, Jo. And I'd come back to Jonathan's U-shaped example, because I think that when we think about that U-shaped example where people sit in the labour market, actually, we've got the vast majority of that 18% sitting in that low-paid, insecure work. And so I would argue that actually, it's really difficult because all of these are obviously intersectional. But I think the work that our communities are doing, the incomes that they receive from them, the security that they are deprived of from that kind of work, all obviously feeds into, for example, the housing that they can access as well. So I think that I would start, if I had to, with work and employment, and really addressing the racialized nature of the discrimination and inequalities that our communities face as the kind of the point at which we should begin kind of challenging some of those inequalities.
Right, thank you. Okay, and then another question, I might, Dave, you may know the answer to this just from the analysis, or know whether we know the answer, and others may have views, but it's going back to the point around economic inactivity and the question about whether some of the increases might be due to care commitments and, putting that in the context of the gaps in social care. So Dave, I don't know if you can say anything about the analysis and whether that tells us anything about where care commitments are driving in economic inactivity, and then I'll see if anybody else has views.
Yeah, I mean, I think, I suppose the first thing to say is I think it's actually quite a complicated picture. I mean, the reporting of ill health has now been the kind of main reason for that increase. But even that increase itself, I think, has some levels of complexity to it. So there was a bump after the pandemic, which does seem to be a bit more related to kind of early retirement, which I think you would expect given people were effectively out of the labour market for a year or so, with furlough and so on happening. And I suppose that effectively has encouraged a cohort of people out. But then what has also become more apparent is this a longer term trend of people with ill health leaving the labour market as well. And I think that's just it's become a bit more obvious in the data, possibly partly because unemployment has been so far at least looking much better, and better than was maybe expected at the start of the pandemic. But then when you start to drill into that group of people, often they can actually report different reasons when they leave, and then the next quarter they report a different reason. And sometimes you can't be entirely sure the reason they're reporting isn't, they've maybe a lot of them have multiple reasons as well. So I think what we haven't done is really drill down into that social care point, but it is something we're interested in looking at. I think on the sort of flip side of that, going, I suppose, a bit younger for participation, we did actually find that I think women under 50 women actually who have previously reported caring commitments had actually increased participation since the pandemic, which I think is quite an interesting kind of flip to the kind of people who maybe are taking time or who might be leaving in their 50s or over to care for an older relative potentially. But it is something we need to look at in some more detail, I think. But I guess ultimately it will come back to an ill health reason to some extent, either on a parent or a partner in the household that they're caring for.
Right, thank you. Okay, and then maybe just one last question I was going to take from the Q&A that we've received. So somebody said, we framed this as talking about the economic case for prevention. We know about the size of the challenges that exist, but how do we make that stronger economic case? Zoe, you talked about some of the ways you're looking at that. Perhaps you could just expand a little bit more on how you think that economic case can be made.
Yeah, absolutely. I think the way we shift it is that collectively between all the organisations on this call, and I'm sure many people listening have a lot of evidence. So obviously it's about working together and making sure we're picking out that best evidence. But I think in a very practical sense, those of us that are working with policymakers and politicians who say they want to move to a preventative system, it's about how to put that into practice. And I think there are some really kind of there are some issues straight in the path as the blockers to moving to a preventative approach that we've got to convince them of otherwise, whether that's about the sort of the double running argument that's made in government about having to kind of, if you move to a prevention approach today, you've got to both invest in the future health of people and deal with the kind of backlog of ill health that we're currently dealing with. As a former Treasury official, I know there are certain kind of economic model blockers that mean that money spent on prevention is not reflected, I would say, properly in economic forecasts, and it's seen as very much a cost as opposed to an investment. So I think there are some key we're at the stage now where, as you said, Joe, in terms of the kind of polling and how people think about this, it's totally obvious, right, to the public in many senses. I think the evidence, much of the evidence, and as Shabana said, is there, and between us collectively, we have a lot to offer on that front. So now it's about making sure we confront the things that are blocking system change, both with policymakers and helping politicians such as Jonathan alike to overcome those barriers and move to a truly preventative model.
Right. Okay, thank you. So we've had some feedback on the sort of poll and the whole range of suggestions of things people say we could be doing now. Just to mention a few that haven't come up so far in the discussion. I mean, so a number of suggestions around early years, which clearly is a really important area and one with very strong evidence. Quite a few mentions around housing, which we've touched on, but also one thing we haven't really talked about is the role of the voluntary sector and the point about need for more multi-year funding for the voluntary sector, which I think is an important point. We worry about short-term funding for the public sector, but the voluntary sector is a challenge as well. So finally, just sort of a few seconds each, I'm just going to go around and just say, to the four panelists, one thing you would like to see done today to support the prevention agenda, literally about 10 seconds. So I'll start with Richard, Jonathan, Zoe, and then Shabna. Richard.
Joe, I do the police to pays on tobacco companies.
Right. Jonathan.
Well, I would ask that Jeremy Hunt in his budget next month, we're still in February, in his budget next month, takes on board some of the suggestions we've been putting forward on reforming the aspects of the benefit system which prevent people moving into work, and really expand employment support services locally in various different healthcare settings. We will want to really build on this work and health unit that has been established, and we'll want to do more of that. So that's coming at that from my perspective as a work and pension spokesperson.
Okay, Zoe, and then Shabna.
Well, fundamentally, we know poverty is the biggest driver of ill health. So I think we can't leave the room without saying that out loud. But from a local perspective, I say restore public health budgets and allow people to be supported locally in their areas, and that can respond to need as it is different across the country.
And Shabna.
And I would just say that all of those should be overlaid with a race equality perspective and an intersectional lens.
Right, thank you. Well, thank you very much to our speakers and to Dave for the presentation. Thank you for all of you who've listened in. The webinar is recorded. It will be available on our website. And also, if you want to sign up for updates from our webinars, you can get a link in the chat. So thank you, everyone, and have a good rest of the day.